I'll just do a quick land acknowledgement. The University of Calgary, located in the heart of southern Alberta, both acknowledges and pays tribute to the traditional territories of the peoples of Treaty 7, which include the Blackfoot Confederacy, comprised of the Siksika, the Piikani, and the Kainai First Nations, the Tsuut'ina First Nation, and the Stoney Nakoda. The city of Calgary is also home to Métis Nation within Alberta, Nose Hill and Elbow Métis Districts 5 and 6. So very happy to have with us Dr. Michelle Keir. She is an adult congenital cardiologist, and she is the lead of the Southern Alberta Adult Congenital Heart Clinic. Her research interests are mixed methods, health systems, and equity. And she is also on the executive advisory committee for the Women's Cardiovascular Health Initiative of the Libin. So I will give it over to Michelle. Thank you.
Thank you so much. So I'm going to speak today about, about managing life transitions in women with congenital heart disease. So we're going to talk a bit about menstruation, family planning, and menopause. So here's the objective and kind of brief outline. So I'm going to give an overview of the history and timeline of congenital heart disease care in Canada, currently describe the current demographics of ACHD care in Canada and globally. And then we're going to talk about some of the challenges facing women with congenital heart disease in accessing care and managing their disease throughout the lifespan. And I don't have any disclosures. So I'm going to start with a case. So this is a patient, Anne-Marie, that I met when I was a fellow in Toronto, who's consented to me using her photo and her story. And so the focus of this talk, the last half, is going to be about family planning and menopause. But just to explain kind of what these patients have gone through throughout their whole life before they get to these phases. So she was born blue with tricuspid atresia, which basically means she has half a heart. So no right side of her heart, just the left side, and had surgeries in infancy so that she could survive infancy. At age 4, she underwent a Glenn modified Fontan operation, which basically means we redirect blood flow away from the single ventricle, the blue blood to the lungs, and then the single ventricle pumps to the body. So you've got a separated system. In 1996, so when she was a young woman traveling, she had a thrombus in her Fontan circuit. So that caused a TIA. And so since 1996 up until current, she's required anticoagulation throughout life. So you can imagine what a challenge that is for a young woman. In 2004, she started to get frequent atrial arrhythmias, which is a sign of Fontan failure or circulatory failure. In 2012, she had another open heart surgery. And then in 2015, she eventually underwent cardiac transplantation, and she's still alive and well today. And so going through, that's the medical history of the patient, but there's also the social history of the patient. So, this is a young person. So she, in childhood, had her parents navigated through her parents' divorce. In university traveling, that's when she had her first stroke. Marriage, career, and family planning was before that as well. And now she's getting to a stage where she's going to be managing menopause, all with this serious heart condition throughout. So you can imagine the complexity of managing that disease course as a young person and throughout the life. And so that's what we try to help them manage with congenital heart disease. So just a bit of brief on congenital heart disease in Canada. So this is an original paper from the Czech Republic. And basically, before modern surgical techniques were developed, 78% of children with hypoplastic left heart syndrome, so not the disease that Anne-Marie had, but a similar one, they died within their first year of life, first month of life. Half of children born with tricuspid atresia, so that's the case that I presented, tetralogy of Fallot and complete AVSD, would not reach their first birthday. And more than 60% of children born with transposition died before 9 months of life. So this was even in the 60s, 70s. Many of these children would have died and never survived to adulthood. But in North America and Europe, with modern surgical techniques, the survival, we're hoping to get them to a normal life expectancy, but certainly to adulthood. So how has that changed from all of these blue babies dying to being managed throughout the lifespan? So this is just a brief history. So in 1944 was the first shunt for palliation of a cyanotic child. So that was the first surgery of any kind. 1948 was the first open surgery. And then in 1950 to 1955 is where they started experimentation with heart-lung bypass in children. So that's when these operations really began to occur. I always like to put this picture up, the one on the left. That's a doctor in Minnesota, Lillehammer, who actually instead of using a bypass machine, he would hook the babies up to their mom as a bypass because it was extremely risky. And he thought the only person that would do that would be the mom to try and save the baby. And so a lot of the initial surgeries were done with these experimental bypass techniques. 1969, so intracardiac repair, so in the 70s, started to be performed in infants and neonates using bypass machines. And then in 1971, so our patient was born in 1979, the first Fontan operation was described for single ventricle physiology. So anybody kind of born before 1970 would have died in infancy. 1970, 80, 90, now all of these children are surviving to adulthood. And so what does that mean for cardiac care in Canada and North America? So this is the lifetime prevalence of congenital heart disease in Canada. So this was from 2014. So the prevalence is still higher in children, but about 6 in 1,000 adults has some form of congenital heart disease. So that's simple, a tiny hole that was closed up in early life, or something severe like our patient where they required multiple surgeries. So what about the absolute numbers of congenital heart disease patients in Canada? So this is the comment that we get all the time, like, oh, you'll see 1 or 2 of these patients in your career. That's actually not the case. So the top number is the absolute number of congenital heart disease. So that's everybody with any congenital heart defect. And you can see in about 2010, the number of congenital heart disease patients that were adults surpassed the pediatric patients with congenital heart disease. So you can see the significant burden of disease there. And then this bottom slide is the those with complex, so similar to our patient. And this is in Quebec. This is from administrative data. So in 2010, they had double the number of adults living with congenital heart disease, almost double the number as children. And those numbers have only continued to climb. And if you think about the infrastructure that supports cardiology care in children, so all the children's hospitals, Stollery, Alberta Children's, that infrastructure is not really there for the adults. And so once they get 18 plus, we need to build that infrastructure to manage them. And then this is similar demographic data. So this is the average age of patients with severe complex congenital heart disease. So in 1985, the average age of all these patients was 11. It increased to 17. And in 2010, the average age was 25. So these patients are living longer, and they're certainly living to adulthood. This is also from Quebec administrative data, but I think this displays the data really well. So looking at the left, this is the burden of congenital heart disease in 1987 to 1988. And you can see a lot of children died in infancy or early childhood. And then the most that survived to adulthood probably had simple or moderate disease and tended to die at an older age. Now what we're seeing is that the mortality has significantly shifted. So very few of these patients are actually dying in childhood, and many of them now are reaching adulthood and normal life expectancy. So this is a novel population, and this is really the first time we're dealing with menopause in patients with severe congenital heart disease and layered atherosclerotic risk on top of their underlying congenital heart disease. So it's a really interesting population. So what about disease burden? So yes, they're all surviving, but are they all doing amazingly well and need very little care? That's really not the case. So what we see is that 10% of all registered ACHD patients are admitted to hospital annually. And that could be for any reason. So it may be because they're congenital heart disease. It may be because of abnormal heart rhythms. It may be for pregnancy and they're delivering their baby. It may be for non-cardiac surgeries. So these patients are now plentiful in their numbers and are presenting to hospital for ongoing care. And then this is the number of hospitalizations for adults with severe CHD. And essentially it's increasing by 2.5% per year. And that's expected based on the number of patients that are surviving. And again, the length of stay is longest in patients with complex congenital heart disease. So those like our patient with a single ventricle and those that are older. So we're now layering their underlying cardiovascular disease that they were born with acquired cardiovascular disease, and then also the cardiovascular disease of aging and other disease. What about, so this is all Canadian data. What about the rest of the world? So again, the average incidence of congenital heart disease is about 1 in 100 and 1 in 1,000 have severe or complex congenital heart disease. And you can see that the incidence of adult congenital heart disease, so this is again adults living in all different income countries, is significantly increasing. The problem is that there is a dearth of heart surgeons and congenital heart providers in lower income and lower middle income countries. And so there's one congenital heart surgeon for 3 million people in Europe and North America, and only one surgeon for 40 million people in Africa. So there's significant disparities in how these patients are cared for across the globe. So what do we do with these patients now that they've survived to adulthood? So 85% of them survive pediatric life, but there are lots of transitions. I put this slide in because the transition we're usually talking about is the transition from pediatric to adult care. So that's the one that we think about is, do they successfully move from pediatric care to adult care? And we know the answer to that is no. So these were in the early 2000s and late 2000s, and this data was just looked at again throughout Canada, and the numbers are relatively similar. So about 47% of patients transitioned from the Hospital for Sick Children in Toronto had appropriate transition to adult care. And I think the interesting point about that is that the sick children and TGH, where the adult congenital clinic, are literally next door to each other. So we joke that we lose 50% of these patients, they just don't walk across the street. 27% of patients, and that's still similar for the rest of Canada, have no contact with cardiologists since childhood. So oftentimes they're presenting in pregnancy or presenting to hospital, and we're kind of scrambling to figure out what's happened in the past and what their care needs are now. In Quebec, and it has one of the more robust care models for ACHD, 79% of patients with severe congenital heart disease had follow-up with an adult cardiologist, although many of them had a general practitioner. And more than 60% of all ACHD patients had no follow-up after their 18th birthday. So we are losing these patients, and that's a significant gap in their care. In the UK, 24% of patients with tetralogy of Fallot, so that's moderate to severe complexity congenital heart disease, were deemed lost. And of late deaths, 48% occurred in patients who were not receiving specialist care. And there's lots of data showing that being in care with an adult congenital cardiologist makes a difference in outcomes. So what are these patients dealing with, and what are their barriers as they transition not just to adult life, but through all of the transitions of life, and specifically women transitioning through pregnancy, menopause, family planning? So this is a great study looking at the psychology of living with adult congenital heart disease. It was from Europe. And this is, oh, my pointer's not working, but it's the middle box is the one that I want you to look at. So one of the main points in the psychology of living with ACHD is that these patients often feel different, and they're trying to normalize. So they don't want to feel different. When you're 16, 17, the last thing you want to do is be different from your peers, right? And so these are main themes that they expressed about kind of getting older with congenital heart disease. So proving themselves, challenging physical boundaries, compensating for limitations, hiding limitations. And so a lot of these are great in regular life, but they can really inhibit care-seeking behaviors because they're very much psychologically saying, I'm normal, I'm not different, I'm just like everybody else. And so that makes it difficult to go for cardiology appointments and visits. What about sports participation in patients with ACHD? So we know that sports participation is lower in adult congenital heart disease patients. I mean, professional sports is obviously significant lower. They have cardiac limitations. But often these children were told you shouldn't do physical activity. And so they didn't participate in sports. So that affects them as they get older. What about education and occupation? So many ACHD patients work full time, but there is a social burden. So we know they have lower educational attainment than their age-matched controls, and that's worse for severe ACHD. And there's lots of reasons for this, mostly missed time at school, missing for surgeries or appointments. And there's also some neurocognitive deficits that we can talk about later. Patients under 40 years of age with congenital heart disease are more likely to be unemployed than their peers, and they're less likely to be in a relationship than the reference group. But the good news is they had significantly less use of alcohol and drugs than their age-matched peers. So what are the barriers to successful transition to adult care? And then we'll talk about barriers to these other transitions throughout life, and those specific to women with congenital heart disease. So these are barriers that were defined in the literature. So a catch center is an ACHD center in the States. they have a different nomenclature. But so barriers to successful adult care are distance from a center, fewer pediatric surgeries, so less engagement in childhood. So the thought is, oh, I'm fixed, I'm normal, I don't need to follow up. Younger age at last pediatric appointment. So we often lose some of these patients. We lose them at transition, but sometimes we lose them at 14, 15, 16. They don't want to come to appointments anymore. And so the chance that they'll be able to make it to adult care is lower. Lack of independence in healthcare decision making, and we'll talk about that a little bit. Poor adherence in adolescence, lack of clear recommendations, men are more likely to be lost, and then pediatric care outside of a universal hospital setting. And I think this last one is really important. They feel well. So I feel fine. I had a surgery in childhood. My heart's fixed. Why do I need to continue following up? So what about neurocognitive challenges in ACHD? So I won't go through all of this, but this is basically, there is some literature about brain function in young adults with congenital heart disease, which makes follow-up and transitions difficult. So this is across the lifespan. So all of the different hits, neurocognitive hits that these children take. So in the fetus, there's significant hypoxia. So because their circulation is different, instead of oxygenated blood gliding to the brain, they're having a mixed oxygenation of blood to the brain. There's also genetic syndromes. We'll talk about that a little bit. In childhood, so they have cyanosis before they have surgery. So their oxygen saturations are in the 70s or 80s when the average babies is in the 90s. Abnormal hemodynamics and bypass surgeries. So having surgeries can also affect neurocognition. And then when we get to the adult stage, so this is transitioning just out of childhood, but through adult life. So they develop heart failure, atrial fibrillation, hypertension, diabetes, obesity is a big one because of lack of physical activity, and then coronary disease. So that's kind of the black box, is we don't know what these layered risk factors will do on patients with an abnormal circulation coming into adulthood. And then I'll just chat about this a little bit. So the fetal brain. So this was a study looking at 33rd trimester fetal brains with moderate to complex congenital heart disease. So that's similar to the patient that we had. So there's a significant decrease in fetal brain size and volume of brain in babies with ACHD compared with controls. And this correlates with umbilical vein oxygenation. So this is a heavy slide, but if you look at the left picture, the kind of the brain on the left side, that's in a baby with a normal circulation, and the three to the right are all different forms of moderate to complex congenital heart disease. And so you can see the brain is significantly more blue in these patients, and it affects their neurodevelopment, which then affects everything going forward. Many of these patients also have concomitant genetic syndromes. So 22q11.2 microdeletion, so DeGeorge is associated with truncal abnormalities. We see this quite often. Williams syndrome, trisomy 21. So these are additional challenges. And then talking about those neonatal insults, the initial thought was you shouldn't operate on these children when they're neonates because they'll have the effective cardiopulmonary bypass and surgery will have a negative impact on their brain development. That's actually probably not true. So no matter what surgical technique you use, there is not much of a difference in the neurocognitive outcomes. And the thought is that that's because of the cyanosis pre-surgery. And so in our patient, 1979 was when she was born. She didn't have her first surgery to separate her circulation until she was about 4 years old. And that was the old practice. Now these babies get operated on first day of life, second day of life with a definitive repair to close the circulation. So there's no shunting to prevent what's called periventral leukomalacia. So necrosis of the white matter related to the ventricles. So 54% of infants with CHD, even after early surgical repair, have evidence of PVL on brain MRI. So what does this translate into cognitive function for these patients, and how does it affect their longitudinal follow-up? So there's been multiple studies and they all kind of show the same thing, which is that these patients have deficits in executive function, problem solving, and planning strategies. But if you look at their IQ on most normal testing, it's actually normal. So they can function in normal life, they look normal, but they have these subtle deficits in executive function, which make follow-up and longitudinal care really difficult and decision-making difficult. And again, those with cyanosis pre-surgery were more prone to these executive function deficits. And again, this is shown, so visual spatial skills, working memory, and also those that have secondary stroke and seizures. So some of these happen in childhood. Some of them, like our patient, happen in later life. And so they obviously have higher rates of neurocognitive deficits. So, what about ongoing cerebral insults? So, this was one of the first studies of older patients with adult congenital heart disease. So, this was again out of Quebec using registry data, but they assessed comorbidities in geriatric adults with ACHD and risk factors for all-cause mortality. They found that the prevalence of ACHD in adults was 3.8 per 1,000. So, significantly prevalent, and only 3% of those patients had severe CHD. So they weren't at this point living to that age. We're expecting that number to rise. And then dementia, chronic kidney disease, and GI bleeding were primary predictors of mortality. So, what about additional communication challenges with these patients? So, we'll talk a little bit about their identity as a survivor and how that can hamper transitions and longitudinal care. Passive self-care tendencies, we'll talk about that. And then some concomitant psychiatric challenges on top of the additional challenges that they're living with. So many patients, when you chat with them about their identity, and there's been lots of narrative analysis and qualitative work looking at this, they identify themselves as survivors. They're survivors of pediatric heart disease. The problem is that the chronic illness in childhood creates a biographical disruption, which necessitates a reframing of self. So they reframe themselves, their families reframe themselves as survivors. They view themselves as unique and special. And a lot of the terminology that we use in children's hospitals really reinforces that. So you're a miracle, you're a survivor, you're a medical marvel that you've survived to this age. The role of heart patient is part of their identity, and that's neither negative nor positive. It has parts of both. But the problem is it also creates a barrier to accepting the possibility of death and understanding risk. So this is a quote from a patient who had cyanosis, and she was discussing her feelings while waiting for transplant. She said, I remember the doctor telling me that it was basically, you can die, and I don't know if it's going to be weeks from now, months from now, a year from now. And so she's telling me this, and I'm looking straight at her, and my sisters are bawling, and all I'm thinking is, you're wrong. A lot of people ask me, how did you survive those 8 months in hospital waiting? So this is waiting for a transplant. And I said, I truly thought I would not die. Something in me said, it's not your time. I don't know if that was the denial or what, but I think that's what kept me going. I knew that my heart was in trouble because it told me about death. I just didn't see it. So this is a patient who's waiting for a cardiac transplant. And so, there's a significant, the part she says, maybe it was denial. It was definitely denial. But also you can imagine it's a reinforcing strategy for staying in hospital for 8 months and continuing to engage with the healthcare system. So it is helpful in survival, but it also can be a barrier to care. So when you're, talking about pregnancy, talking about risk, these patients have a real different estimation of what risk is because they've basically been living at risk since birth. And for this patient, so she underwent a successful heart-lung transplant, but she never filled out any advanced planning forms because she thought that it would be kind of a bad omen. And so you can imagine that the familiarity with the healthcare system and things that would make other patients stressed, like, oh, you have to have a heart transplant, are kind of routine for these patients. And so that can actually be a barrier to care. This is another patient who has since passed away. So he was a mustard patient, which is a complex surgery that we won't go into. But he had actually embraced a palliative care strategy and said, I don't want to go for transplant. But this is what he had said. So my younger daughter and my wife are really hanging on to hope. They nicknamed me the odds beater. You beat the odds for all these years. You beat them then. You're past the curve. So you're going to keep on beating the odds. And so, yes, it's positive messaging, but it's not necessarily realistic. So family members and loved ones also embrace the survivor identity, and they have difficulty accepting new realities that growing older and living with congenital heart disease is a challenge. One of the other pieces that's really important is passive self-care tendencies. This is from a study looking at how these patients want to receive information in healthcare and behavioral involvement. And essentially, it's that they're very passive. So they say, you tell me what I need to know. I'm going to listen to the doctors, and I don't really want to be involved in decision making. You guys tell me what to do. And so, yes, in some ways, I think some physicians would think that's an excellent thing. But in other ways, it's very difficult to manage complex decision making. In addition, so concomitant psychiatric challenges. So 21% of these patients report health-related post-traumatic stress disorder symptoms, and it's about 3% in the general population. So that means coming to hospital, coming to appointments, getting blood work is much more anxiety-provoking in these patients and can be a significant barrier to care than average. 35% of these patients have anxiety, and 13% of them have depression. So these are all really I wanted to set the global landscape or the Canadian landscape for this patient's care. And then now let's talk about specifically care of adult women with congenital heart disease. So what do we know about the gynecological health of women with ACHD outside of pregnancy? And the answer is very little. So I have some slides. We know a little bit. But I think this is a really important point. And the reason I didn't, so pregnancy is a whole other talk in these patients, but the reason I didn't want to include it is because up until this point, much of the research in women's health and congenital heart disease has only focused on pregnancy. And I think that really speaks to what we value with regards to women's health going forward. So, we say, okay, women's health and congenital heart disease is, can they make it through a pregnancy? But not for, women who choose not to have a pregnancy, family planning in these patients, menopause. So there's very little research in these patients. And I think it speaks to what we value in society and where we need to move going forward. So what do we know? So menstrual patterns in women with congenital heart disease. So this is the only study looking at this. So it was a retrospective survey of 98 women in 1995 with congenital heart disease. Mean age was 33 years compared to age-matched control. So we know that women with congenital heart disease have late menarche compared with controls. And that happens much later in those that are cyanotic. Longer cycle lengths, so fewer menstrual periods, were reported by women with congenital heart disease. So there's also in this study quite a high rate of hysterectomy in women with congenital heart disease. So 7 out of 98 women. And again, the average age of this cohort was 33. Hysterectomy was most often performed to prevent pregnancy and control irregular or heavy menstrual bleeding. And so if you think about our original patient, she was 16, 17 when she had her first stroke and had been on full dose anticoagulation ever since that point. So there's a very high rate of dysfunctional uterine bleeding with these patients, which may reflect an ovulatory state and also can reflect the fact that many of them are anticoagulated. I'm going to look at Christina because I know that, most cardiologists don't have menstrual pattern and history as part of their general history for women with heart disease coming into hospital. And I heard a hematologist talk last year, and so I have to steal this, but she said, you should always believe women except when they tell you they have normal periods. Which I thought was an excellent statement. So we know that many of these patients have dysfunctional uterine bleeding. What about birth control usage in ACHD women? So this was a study from the 2000s, this is 2 studies from 90s and 2000s. So they found that women with congenital heart disease often get inaccurate advice regarding contraceptive options. One that I will always remember is a woman who had a single ventricle circulation and had an unplanned pregnancy. And she said, well, they told me I couldn't get pregnant. And we said, well, yeah, you shouldn't get pregnant, but you physically could get pregnant. So because everyone had told her whole life, you can't get pregnant, she thought that she had a physical barrier to pregnancy, when in fact it was that she should not get pregnant. So we know that women get inaccurate and incomplete advice regarding contraception. Patients with CHD usually begin engaging in sexual activity later, but we know they engage in riskier behaviors. 88% of young adults with CHD reported using birth control, so condoms, hormonal, or other, and most of them never discussed this with their cardiologist or what the risks were associated with it. So let's talk about challenges that are unique to women with ACHD. And I think a lot of these are questions because the research is not there to answer these questions. But we'll go into a little bit of the research on menopause later. So does age or repair affect long-term risk of an ovulation? So women operated on 6 to 10 years after menarche. So that's people that are left blue. We often see this in patients that come from other places where they didn't have surgery available. So they may not have had surgery in infancy like they would have in North America. They moved to Canada at 15, 16, 17, and then have surgery at that point because reparative surgery is still an option. So we actually have quite a large population that had surgery in their teens or early 20s. So these women have menarche or after menarche have higher rates of menstrual irregularities. Does amenorrhea or dysmenorrhea in this population represent an ovulatory state or unopposed estrogen? We don't really know. Does long-term anovulation result in greater risk of endometrial and or breast cancer or osteoporosis? Again, we don't know in this population. So we'll chat about the very few things we know a little bit later. Other challenges. So how common is menorrhagia? So we have a couple of really small studies. But what are the effects of exaggerated blood loss on the long-term health of women with CHD? So this is data that we're not collecting in cardiology clinic. But we would imagine, especially for women with cyanosis, because they're blue, they have to have aggressive erythropoiesis. So they have to have more red blood cells to carry the lower amount of oxygen that they have. So their hemoglobin is often 190, 200, 210. So if you have menorrhagia with that, does that destabilize that erythrocytosis? There's lots of great evidence about iron deficiency and how it affects heart failure patients, but we have none of that evidence in women with congenital heart disease. So how does iron deficiency, menorrhagia affect the hemodynamics of CHD? And with cyclic progestin therapy, can we treat an ovulation and improve long-term outcomes? So again, these are things that we don't really know. What about the long-term effects of anticoagulation? So we know there's a higher risk of ovarian hemorrhage in ovulating women who are taking anticoagulation. What are the effects of menorrhagia on medication compliance or lifestyle? So I have one patient who was on warfarin for mechanical valve, and she told me when I asked her about her menstrual periods that she takes her warfarin every other day when she's on her period to manage the menorrhagia, which is extremely risky because then there's a risk that she'll thrombose her valve. But so I think women are often managing these things on their own because the advice is not really there. So what are the effects on medication compliance, lifestyle, ability to work, ability to participate in society? Does that menorrhagia result in anemia, and does that have deleterious effects on long-term cardiovascular function? We think it does, but we don't know for sure. And should anticoagulation parameters be different for young women and young men? So all of our dosing is standardized. Our INR targets are standardized. Is that legitimate? Should we be modifying those based on the needs of women with or menstruating women? And again, the answer is we don't know. What are, again, long-term effects of contraceptive use? So a risk of an unwanted pregnancy. So we're talking about lots of complication there. Pregnancy is not contraindicated in most women with congenital heart disease, but is high risk. So how do we balance those benefits? So we know that we should avoid estrogen-containing compounds in women at risk of thrombosis. So many of our patients are at risk of thrombosis, but we don't know if that's the same as women that have a thrombotic workup. So DVTs, antiphospholipid syndrome, is somebody with a mechanical valve or somebody with a Fontan equivalent to that in their thrombosis risk? We don't know. Progesterone-only options have been shown to increase lipids. So in the long term, if somebody's on progesterone-only birth control for 20 years and they have congenital heart disease where they're at risk of atherosclerosis, how does that affect things? We have no data on what the effect of emergency contraception is on women with congenital heart disease. And also, what's the risk of IUD insertion? So the patient that I presented at the beginning actually had a code blue and at a gynecologist's office because she has a single ventricle circulation. She's preload dependent. When they put an IUD in, she vagaled and her heart stopped and she died a little bit. So they called an ambulance. She went to hospital. It was fine. But so all of these things are more complicated in women with congenital heart disease. And we don't necessarily think about those things when we're providing clinical care. And then we also don't necessarily treat them properly. So what about what we do know about menopause with ACHD? So menopause has established interactions with atherosclerotic cardiovascular risks in all women, even those without pre-existing heart disease. There's no data on cardiovascular risk profiles of postmenopausal women with ACHD. So what are the atherosclerotic risks in all postmenopausal women? So this is what we see. We see a steep rise in LDL, so bad cholesterol, modest rise in lipoprotein a. Triglyceride levels increase in women as they age. There's an increase in central and visceral fat and decrease in lean mass. This can be a significant challenge in congenital heart disease patients because many of those living with an abnormal circulation are already sarcopenic. So what does this do to their body mass composition? We don't know. And blood pressure steadily rises post-menopause. So due to their postmenopausal atherogenic lipid profile, and this is not from congenital patients, this is from all women, we know that women receive similar benefit from primary prevention statin than men, but are prescribed them less often, and are frequently undertreated. So they're often started on a low dose, and then that dose is not accelerated based on biologic parameters. So that's simply bias in the medical care of women. What about menopause in ACHD with special populations? So in women with unrepaired cyanotic CHD in adulthood, or cyanotic women who underwent surgical repair, we know that anovulation increases the risk of endometrial carcinoma. Aside from gender, we know that all patients with congenital heart disease have a 23% higher lifetime cancer risk than average. The thought is that the mechanisms that are cellular repair mechanisms that would prevent congenital heart disease in a fetus are in some way suboptimal in adults with congenital heart disease. So the thought is that their lifetime cancer risk is higher because of multiple things. So syndromic abnormalities, decreased repair mechanism, and then also we don't really know what the impact of longitudinal imaging is on these patients. So we know that they're already at higher risk of cancer. Does that anovulatory state, because they were unrepaired cyanotic or repaired later on in life, affect that 23% increase? So is it higher? This combined risk of increased malignancy should be carefully considered when deciding whether or not to treat menopausal vasomotor symptoms with estrogen-containing HRT, because we know that increases the risk of endometrial cancer slightly. So yes, in the average woman, we would say shortest dose or smallest dose for shortest period of time, it's safe, but in the congenital heart disease population, is it? So we don't really know. What about those with a single ventricle? So like our initial patient I presented, so transitioning through menopause, they're going to have unique challenges. So we know that anti-Müllerian hormone levels indicative of ovarian reserve are lower in women living with a Fontan circulation, especially those over the age of 35. The thought is that there is some sort of ovarian cyanosis the same way that the rest of their body is cyanotic in early life. This predisposes women living with a Fontan circulation to premature ovarian failure and early menopause. So yes, we think the average age of menopause is 50 in women with congenital heart disease. Is it going to be earlier? And then are we dealing with the cardiovascular effects earlier than in the average person? Premature menopause, age less than 40, confers greater atherosclerotic risk, which will need to be carefully considered in the overall management of those living with a single ventricle. And the minimally increased risk of thrombosis associated with HRT, so significant, quite low, but it probably outweighs the potential benefit in women with a Fontan circulation and or a mechanical valve. Most other women are probably fine, but again, we don't really know. The other problem is that many patients with single ventricles and systemic right ventricles, so the wrong side pumping to the body, are anticoagulated. Again, dysfunctional menstrual bleeding and anemia, but that can make menopause symptoms worse. Iron deficiency and anemia in this population can precipitate reduced exercise capacity and kick people into heart failure. And women with congenital heart disease and menstrual cycle disorders are more likely to have heart failure and low cardiac output. This is a real problem because heart failure and congenital heart disease often does not present the same way as traditional heart failure. And the symptoms can be difficult to recognize. So it can be fatigue, sweats, flushing, palpitations, which are all the normal vasomotor symptoms of menopause. And so do we treat those symptoms with HRT, or should we working these patients up for heart transplant? So essentially, there's lots that we don't know about how these patients are going to progress throughout the lifespan. So I will stop there. So thank you so much for listening, and we'll see if there's any questions.
We're just going to hear the psychological component of caring for the patient.
Yeah.
Questions? Anything known about what pregnancy does to symptoms?
Yeah. So it's, again, I think speaking to kind of our cultural value on women and what we research. So there's lots of research that would be a whole nother talk about looking at cardiac outcomes in pregnancy, but all of the research looks at, are you going to survive a pregnancy or not? Which I think, as somebody who has kids, the pregnancy sucks and is an important part. You want to survive it, but it's the other 18 plus years that are important, right? And so there's no data on longitudinal outcomes. So there is a registry in Canada that's coming out of Hamilton, Toronto, and Vancouver, looking at long-term outcomes in these women. Because right now, if someone comes and says, okay, I have this congenital heart disease, what's my chance of getting through pregnancy? I have pretty good data on saying, this is your risk of needing a transplant. This is your risk of arrhythmia. This is your risk of heart failure. This is your risk to baby and survival. But I have no data on what that does to their long-term survival. So does that mean you're going to need a transplant 10 years before somebody else? One of the other big things that we have not counseled people, but we've started to, is looking at sensitization. So every pregnancy you're exposed to dad's antibodies. And so there's a risk that that'll make it harder to get a transplant going forward. And so we have no data on what pregnancy does to longitudinal risk. So the only robust data in congenital heart disease is, will you survive the pregnancy? Will the baby survive the pregnancy? Not in what does that mean for you long term? Yeah. Yeah, so we don't know. So this is just anecdotal. So I have a few patients that I've prescribed it. The first thing you want to, or not prescribed it, but spoken with their family doctor about whether or not it was safe to prescribe. So the first thing you want to make sure is that these vasomotor symptoms, so the fatigue, hypertension, difficulty sleeping, sweating, are not symptoms of heart failure or other cardiovascular disease. Because I think what can happen to women is they say, oh, well, it's just menopause. That's normal, right? And so that's an important piece, is to make sure that we're up to date on all of their imaging, that their screening has been done, that we're not missing something serious related to their heart. Once that's been established, there's really no data on long-term outcomes. So we tend to use the similar advice to the general population, is that the lowest dose for the lowest amount of time possible to control the vasomotor symptoms and to get you through that period is likely safe. Again, in women who are anticoagulated or have a risk of thrombosis, we don't know. I think if their menopausal symptoms were really affecting their quality of life, and you have a robust conversation with them about what we don't know, then I think it's fair. So I have said to family doctors in different situations, so a patient that had an aortic dissection, she's really suffering with her menopausal symptoms. Her quality of life is terrible. Yes, there may be an increased risk, but let's try it and see what happens. And so I think that the other piece with patients too is that what I find is that telling them we don't know is actually sometimes really useful for patients in their own decision making, because they expect that we have all this data, right? That I can say, yeah, this is your risk if you take it, this is your risk if you don't. And so even just saying to women, it hasn't been studied, we don't really know, is, I think, useful in that counseling. And I think they appreciate that honesty, that we don't have the data there. And then the other step is we need to develop the data. Yeah.
To prevent pregnancy.
Yeah.
But how often would that be recommended, or under what circumstances?
Yeah, so never.
Oh, okay.
So that was an American study, and it was a retrospective study, and they asked women why they had had a hysterectomy, and then they tried to review the medical record. So it was from California, I think, California. And so my guess is that there was some form of menorrhagia, and then also they didn't want to have a pregnancy, or they wanted to prevent pregnancy. And so that was, yeah, so I think that came from the patient, was their perception of why they had a hysterectomy. We usually do not recommend that. I've had a couple of patients that have ended up having hysterectomies because of dysfunctional uterine bleeding, because they tried everything else. They tried hormonal therapy, they tried ablation, and eventually the only option was hysterectomy. But yeah, not usually for pregnancy prevention. And a lot of these patients, it's when you ask what they're told too, is, so I have one patient who's in her 20s. Pregnancy is not contraindicated from a cardiac perspective, but it would be higher risk. And she doesn't want to be on hormonal birth control, so she wanted a tubal ligation. And she had to see, I think, 3 obstetricians before someone would perform the tubal ligation, because they were like, you're 25, you might change your mind. What if you meet the right guy? Well, yeah. But so No offense to there are lots of great guys, but yeah, that's not how we talk to people. But so yeah, so a lot of that comes into play. Whereas so care seeking in this population is, even if they're advocating for themselves, is really misunderstood.
Yeah.
Yeah. Yeah.
I have my hand up, but you can't.
Oh, sorry, Reese. Yeah.
That's okay. So you mentioned in Toronto, 50% of the
Yeah.
what's that like here? Where
Yeah.
children's and in Edmonton.
Yes, yeah. So I think we're not entirely sure. So the Catch Network, which is the Canadian Adult Congenital Heart Disease Network, we did a survey in a couple of years ago, and it was looking at how many patients. So the only way to extrapolate this is how many patients are in our clinics, and then how many should be in our clinics based on demographic data. And so I think the number was in Canada about 30,000 patients with congenital heart disease, some form, not all severe, but lost to follow-up. So we think our numbers are similar. So we think we lose probably, I mean, about 30 to 40% of patients don't make it across the street. Even if they do make it into our clinic, our rate of loss to follow-up, despite admins who are amazing and, saying, I have some patients that I'm like, you don't need an appointment. Just when you show up, we'll see you. We'll get you an echo. Just come to PLC when you can, kind of thing. So even with really open care paradigms, we still lose a significant number of patients. We lose more men, I think, than we lose women, because women tend to seek healthcare for pregnancy and contraception and other things. So they end up getting hooked back into the system. But there's all of those barriers to longitudinal care. And I don't think we haven't managed to address them properly. And a lot of them are socioeconomic. Yes, Christine.
You had a magic wand right now. With what would be sort of a top wish of making back with regards to driving future care?
Yeah, so I think that I think one of the biggest missed targets is psychological care of these patients. So I think, I wanted to say menopause care because that's what I wanted. That's a research target for sure. But I think one of the big missed pieces is psychological care in these patients. So if you look at every narrative study, every qualitative study, every quantitative study, we are undertreating psychological disorders in these patients that are barriers to care. Every recommendation from every society says you should have a psychologist in your clinic, you should have robust access to mental health care. We have the Hearts and Minds Clinic, which is excellent. So Dr. Raj sees many of our patients, but we do not have an on-site psychologist. We don't have a social worker associated with our clinic. And so I think, I don't think any of the clinics in Canada do, just because it's not valued or underfunded. And so I think if we had robust psychological care for our patients, it would significantly improve longitudinal outcomes. And yeah, it's hard because, I'm not a psychiatrist. So we try to be as empathetic as possible, but our goal really is, to make sure that their heart remains stable. But all of these other things are significant barriers to care. So, I would like everybody to be housed and for a basic income and a psychologist available. But all of those, so that's my magic wand. But I think that's the big next area, is that we've proven that it's necessary. And then now, can we prove that it works in practice? But nobody wants to pay for it. Thank you.
Just like